know, you don't know me well enough to know that I'm pretty sarcastic at baseline, okay? So like when I come in, I'm like, I sacrificed my lunch, you know, I'm just teasing, okay? You guys I hope you know that I'm just totally messing around and making light. You know, some people take it as literal, like I really think I'm like have no humility or something, or I'm just up here like making sure you know what I've done for you, and that's not what I'm intending to do. I'm just making a joke, okay? I'm just trying to get your attention. I'm trying to be playful. I can tell your energy's kind of low today. I like to bring you up a level or two, because my baseline is like an 8, right? Usually, maybe, I don't know. I mean, I'm always like that until I finally go to sleep, you know, so no matter what environment you see me in, if it's at the club or at my kid's soccer game, I'm equally emphatic all the time. Okay. And so I know that that quick little review probably wasn't anyone's ideal, including mine, as far as review goes, but I just want to hit some salient points. So for those of you that still need to listen to them, or for those of you that actually did listen to them and you don't listen to them again, it just gives you some areas to pay attention to. I'm going to further kind of discern some of those ultrasound images, because I know some of that is foreign and kind of hard to discern. One image, I had a really intelligent question at the break: how do I distinguish B lines from, you know, these marching ants and normal lung sliding and you know, things that we haven't had. If I had my druthers, we do ultrasound block 5 up front, so you're adept at ultrasound for everything else, because there's so much application of ultrasound at the bedside. It's the only tool since the invention of the stethoscope that we can use at the bedside to help us diagnose a patient. It's pretty fantastic. And it actually empowers you as PAs. Well, I guess the ECG is one of those things too, I guess. So I guess it's also the ECG. So how confident, raise a hand, how confident are y'all in looking at an ECG? Like right now, I put one in front of you, thumbs down, super thumbs down. Some people are like, yeah, I can pick out a few things. Well, I will tell you, and this is an emergency medicine focused class, and so in emergency medicine, when we do ECG out of 10 patients, like 6 or so will get an ECG, because a lot of things have overlap. Maybe it's age and comorbidities. Maybe you know, even though they have a cough because of their flu, if they said my chest hurts, they get an ECG within 10 minutes. It's a national metric. And so we see a lot of ECGs, most of which have no underlying pathology. Most at the time, if we see something, it's like non-specific changes. But our only job in the ER when we see an ECG is to timestamp when we saw it, because that's a national metric. They have to do it within 10 minutes of the patient's presentation. And I, as a clinician, has to put my initials on it and say, no STEMI. I just have to make sure I don't miss a STEMI, okay? Now, if I'm really doing my due diligence, I'll put, you know, ischemia, no STEMI, but by law, I only have to write, I saw it within the 10 minutes, and it's not a STEMI, okay? So in emergency medicine, we're looking at ST segment elevation MI, hence STEMI, which is transmural full-on heart attack, versus ischemia, which is ST depression. And that is what I want you all to really focus on. So now you're like, okay, that I can do. My thumbs down went to thumbs up, okay, which is awesome. Okay, so but we're just going to go back through a systematic approach on how to do this so that you're more successful. And this is the only class that I've done this for so far. I've seen so many people struggle this block with ECGs. A lot of it was the turnaround from the ECG instructors and stuff, and now we got DeBoer, who's fantastic, and he's stabilizing the program, but it was a little crazy there for a little time, you know, for quite a while. So this won't take long. I know you're anxious to get out of here. I realize you guys are very possessive and protective of your time. And I actually, and I don't think it's over the top, because I too am very protective of my time. Okay, I am, because as you get older, especially when you get my age, you realize that you can't get the time back, right? You want a nap. You want to go work out. You need some personal time. Maybe some of you, this is the only time you get to actually spend with your family or pick your kid up from school that one day. You know, so I get it. So we're going to go through this systematically. I'm going to show you how I do it. I know you might have been taught a different way, but this is a review, and it's to help you be successful, okay? Everybody with me? All right. All right, so when you look at an ECG, you have to be kind of like OSCE, all right? You have to have some sort of systematic approach. You gotta you know, be organized, right? So what do we look at first? Yeah, so a lot of times, besides the obvious, right, patient, right, all that stuff, right, we want to look at the rate. And you can do an eyeball, is it fast or slow, right? or we can actually kind of calculate the rate. Now the machines will do it for us, and that's nice, and that makes us lazy. But it's really nice to know, and you know, that we can do that. How I look at an ECG, I look at the rate first. I look at the rhythm. What does that mean? Okay, is it regular or irregular? Is it sinus or not? How do I know if a rhythm is sinus? There's a p-value. Not a p-value. There's a p in between or before the QRS, right? There's a p before every QRS. That's a sinus rhythm. So just by eyeballing it, I can tell if it's fast or slow, if it's sinus or not. Is that fair? Okay. And rhythm matters, right? And then we can go into, is it junctional, is it ventricular, is it wide, all that stuff. But just eyeballing it, for our intents and purposes, ischemia and STEMI, rate, rhythm, intervals. What is that? PR interval, QT interval. I would say in emergency medicine, those are probably the two primary most important ones, because PR helps us determine if there's blocks. You know, AV block, 1, 2, or a complete heart block, right? And then QT interval matters. Why is that? Because the time it takes for the ventricles to repolarize during that time from depolarization to repolarization is affected by a lot of medications. And if they already have prolongation of their QTC, we say C is corrected, their QT interval, if they already have a prolonged one, I don't want to give them a medicine like Zofran or a fluoroquinolone and make that worse and create an RRT phenomenon and put that patient into ventricular fibrillation. That's bad. Okay, so those kinds of things matter. So in terms of emergency medicine, those are the intervals that make the most sense. Morphology, what's that? I mean, you can get really into the weeds with this, and I think this is what Commander Moore did with you guys, right? You know, looking at the P, does it look like it's P mitral? Is it a peaked P? Is it a peaked T? You can get really into it, but for our intents and purposes, when I say morphology, it's almost synonymous with ischemia and infarction. Instead of, you can just almost eliminate one of these and put them all together. So instead of the 7-minute abs, you get the 6-minute abs, and you get the same result, okay, up here? So morphology, we're looking for ST segment elevation or ST segment depression. Is it ischemia or is it infarction? That's morphology. And then you can kind of dissect further, obviously, depending on how keen you want to be. But to be successful in block 2, you need to be able to identify some specific things which we'll teach. Axis, okay, which leads do we look at to identify axis? 1 and F, very good. All right, and we're going to go over that in just a moment. Does axis matter in the grand scheme? A little bit, right? Is it going to change everything I do clinically because of their axis? Because they have a mild right axis deviation? No, absolutely not, okay? But it's important to know in certain pathologies. And then hypertrophy. Is hypertrophy a problem, potentially? Maybe one population that it's most important to identify hypertrophy in. I'm sorry, what was it? Young athletes, young people that present with syncope, right? So that would be one time I don't want to miss a hypertrophy, and that's going to be covered in our cardiomyopathies lecture. So I'm going to hit the highlights for emergency medicine. Okay, so rate, fast or slow. You guys, the ECG will tell you the rate, and if I give you an ECG, it's going to have the rate either on the vignette or it's just going to be in the vignette. I'm going to give you the vital signs, okay? But you can do the box method, but in order to do a box method, you have to have a regular rate. So if you're in AFib or something, or the patient is, you can't do that. You just count how many complexes that you see on the strip and multiply it by what to get the rate? 6. Okay, very good. So if this was somebody's real rhythm strip and I saw 1, 2, 3, 4, 5, 6 in this and multiplied it by 6, the rate would be 36, right? If it was an actual strip. Okay, but it's not. Instead, this is just showing you different rates. But if you have a normal ECG and you count 5 big blocks and how many QRSs there are between those. Okay, if you go from QRS complex to QRS complex and divide that by the 300 by 5, right, by the 5 boxes, that'll give you a rate. Okay, or you can memorize, right? 300, 150. What's the next one? 300, 150, 100, 75, 60. Anyway, it's gonna be easy for my class because I'm gonna give you the rate, okay? But there's different methods to calculate what the rate is. Now rhythm, I already told you, in order to discern what kind of rhythm it is, we need to see, is there a P before a QRS? If there is a P before every QRS, it's sinus, right? What if there's not a P? What kind of rhythms can they be? They can be junctional, it can be ventricular, it can be a paced rhythm, right? They can have a pacer, okay, and they usually look wide. And then we also want to know the pattern, regular or irregular. And if it's irregular, is it irregularly irregular, or is it irregular in a pattern, right? That helps us discern AFib versus flutter versus stuff like that, versus multifocal atrial tachycardia and all these other things that we're not going to get into. Intervals, I told you what was important, okay? You guys remember how to measure and what interval is what? You guys remember this a little bit? Am I going too fast on this one? Okay. So PR interval is the beginning of the P all the way till the dip of the QRS complex, right? And what's a normal PR interval? Yeah, 3 to 5 boxes, 0.12 to 0.20, really good. Does it matter in emergency medicine if it's a little short or a little long? It can, actually. If it's a little short, if they have a shortened PR that's less than 0.12, my spidey sense is looking for any kind of pre-excitation syndromes, because that would predispose somebody to sudden cardiac death. So WPW, LGL, they have a short PR interval, okay? Longer PR intervals, as long as they're regular and they don't vary, that's just a first degree AV block, okay? But if they start varying, now I gotta start looking at, is this a second degree, is this a type 2, or is this a third degree full heart block, okay? So PR interval can matter for emergency medicine. What about the QRS complex? What about that interval? Does that matter? Normal is 0.08 to 0.12. Does it matter as much in emergency medicine? Probably not as much, right? Maybe some drugs that we give can affect it, but you know, we in general care if it's just thin or wide, all right? Because that kind of tells us some information. All right. What about the QT? We talked about that briefly. The QT, where do we measure it from? You guys know it.
Start the Q.
Okay, what's that? Go ahead.
I was going to say start of the Q to end of the T.
Yeah, thank you. And what is it really measuring though? What's happening during that time? Yeah, it's the time from the ventricles to depolarize and then repolarize, right? Is that what's happening? Okay, good. Is there anything in between there that I didn't talk about segment-wise? There's a little tiny thing called the ST segment, which is very important in emergency medicine, okay? That's that natural pause here, okay, between the S and the T, this ST segment. And that's generally what we're paying attention to in emergency medicine to see if it's elevated or depressed, the ST segment. It's supposed to be an isoelectric line, and it represents the time between depolarization and repolarization of what? So what's happening after, okay, what's happening during the P? Atrials are contracting. What's happening in the QRS complex? The ventricles are contracting, okay, and somewhere in there the atria are repolarizing. What's happening in the ST segment? That's the time in between depolarization and repolarization of the ventricles. And that's why it should be isoelectric, like there's not much going on right there. Just depolarize, it's kind of resting before the ventricles repolarize, which is the T. Are we with me? Okay. All right, just making sure. So morphology, we can look at the P wave and discern some things, right? If we look at that P wave and really dissect it, we could say, oh, it looks like a little M shape and it's a little tall. It could be a P mitral, which might indicate some sort of pulmonary pattern, or left atrial enlargement, or a tall peaked P wave might have also a pulmonary pattern to it. You know, I'm not going to make you dissect the ECGs to that degree during this block. I need you to pick out ischemia and infarction and reciprocal changes, okay, just to reiterate. We talked about the QRS complex. Sometimes the QRS complexes look funny, They look like little rabbit ears. You guys learned about bundle branch blocks? Can it be a normal variant? Can normal people have bundle branch blocks? Anybody here have a bundle branch block? I know I do. No? Okay, I'm the only circus freak in the class. Okay, got it, moving on. Okay, left bundle branch blocks are a little more concerning, correct, versus right? Would you agree? So they could be monophasic, notched, they can present in a lot of different ways, but do you guys remember anything from your cardiology teaching? What is like a STEMI equivalent regarding left bundles and a certain criteria some people think about? Scarbosis criteria, okay. I'm not gonna make you know Scarbosis criteria for my exam. How happy are you? Yeah, me too, okay, because it's hard, all right, but they look at and you kind of gauge the degree of discordance or concordance to discern scarbosis, but we're not gonna get into that, okay. And then T-wave morphology, if we're looking at the T's, does that matter, the way the T's look?
Yes.
T's are very relevant for emergency medicine. If it's a peak T, sometimes we call it hyperacute T. That could be beginning, early stages of acute coronary syndrome. What else can present with a peak T? Hyperkalemia or other electrolyte abnormalities, okay? Very relevant to emergency medicine. So I know I'm flipping through these pretty quickly. It's just supposed to be a review. We talked about axis, and again, we have normal, we have right, we have extreme right, and then left axis. And again, not gonna have to really be relevant for my block 2. My block 2 is acute coronary syndrome focused, okay? Hypertrophy, we talked about this, it's relevant. I'm gonna do a cardiomyopathy block. Hypertrophy does matter, and you do wanna kind of look at it. And how do we calculate or can eyeball if somebody may have left ventricular hypertrophy? Okay, good. Sometimes there's a bunch of different criteria actually out there, but what we typically use will the number of blocks are the S and V1, and we add that to the R and V5 or V6, and if it's greater than 35 millimeters by definition, that's left ventricular hypertrophy. Is all LVH bad? What about athletes' hearts? Do they have a little LVH? Yeah, baseline. But we're really worried about the young athlete and some other criteria. So LVH by itself may not be enough to slam dunk a dose like a hypertrophic cardiomyopathy. We need to do some other things, but we need to be able to pick out LVH. RVH is a thing too, and who might we see right ventricular hypertrophy in? What type of subset of patients get RVH? Anybody with pulmonary disease, right? Because of the lung. Okay, very good. All right, so this is the meat of it, okay? I know I flipped through that fast. It's just a reminder, and this is available to you on the Canvas, and there's even a PDF form so you can read about it. But I just want to remind you, this is what you learned last semester. ST elevation, okay? What identifies or what is the criteria for STEMI? For ST segment elevation MI, what are the criteria? What makes it a STEMI? If I just see a little elevation of one lead, is that a STEMI? So it's got to be greater than 1 millimeter, okay, of elevation in 2 contiguous leads. So that means if I'm looking at an ECG and I see lead 1 with a little elevation and lead 2 with a little elevation, those are contiguous, right? Does lead 1 go with lead 2? No, that's not contiguous, okay? We don't read an ECG in order of it, the way it looks on the ECG. We read it in terms of where it correlates with the heart. So lead 1 actually goes with L and 5 and 6. So that's when it gets confusing. Leads 2, 3, and F go together. Leads V1, 2, 3, and 4 go together. So when we say contiguous, you gotta be reading them with their partners, their groups, okay? Does that make sense? So it's got to be contiguous within their groups. I'm going to remind you of what I'm talking about. You can have elevation, which is STEMI. Again, greater than 1 millimeter and 2 contiguous leads is criteria for STEMI. How many times do you think I've called a STEMI in the emergency department and the cardiology team came down and they said this isn't a STEMI? A lot. too many, I can't even count, right? One time, I called a cardiologist and said, this isn't a STEMI, but this patient has pretty remarkable elevation in just AVR, have active chest pain with a good story, a history of coronary artery disease, and a lot of T-wave inversions, okay? Cardiologist says it doesn't meet STEMI criteria. Wait a couple hours, troponin came back positive. That cardiologist left, the new cardiologist comes on. I call him and said, are you the one gonna take her to the cath lab tomorrow? And he's like, she's got a STEMI. You should have called us 2 hours ago when you saw isolated ST elevation and AVR. And I'm like, by definition, that doesn't meet STEMI criteria, right? It's supposed to be 2 contiguous leads, that's the accepted norm. But if you're a cardiologist, I suppose you could call whatever you want a STEMI, right? They could roll up on somebody who has no ECG changes and do an echo at the bedside and say, this person's having wall motion abnormalities, it's a STEMI. Okay, so if you're a cardiologist, okay, you don't have to follow the standards, right? So it's different. We are not that, so I'm gonna follow the criteria. So if I overcall it, that's okay. My goal is to not undercall it, right? That's our goal, don't undercall it. So it's okay, I can take it, you know, my ego can take a hit. Sorry, it looked elevated to me. I know there was a prior ECG, looked a little similar, just a little worse. I'm glad you came down, thank you for your expertise and your time, you know, and they go back up. Okay, it's not that big of a deal. It's just a minor ego blow, okay? But it's better to be overcall than undercall. What about ST segment depression? Does this matter?
Yes.
What is that indicative of? It's ischemia, right? And if we let it progress, it could progress to a STEMI, or it could be an NSTEMI already happening, okay? And that's bad. So any kind of depression is probably ischemia. And if we don't intervene right now with the aspirin or nitro for their chest pain, or maybe even heparin, then they could actually go to a transmural full thickness lesion of a STEMI, and that's bad. So if we see ischemia, it actually gives us a chance to intervene and save them and be, that's where heroics, we're heroes that day, okay? All right, T-waves, can they tell us a lot about somebody acutely? We talked about already, T-wave abnormalities are relevant to emergency medicine. Peaked T-waves can be what? It can be hyperacute T's and a STEMI. Okay, that's what's happening first, or it could be some major electrolyte abnormalities, all right, very good. Q waves, what about those? Are those relevant for emergency medicine? Yeah, so sometimes people have old Q waves. Sometimes they're developing new ones because they didn't come in, they've had chest pain for 3 days and their new ECG just shows Q waves. There's no STEMI, there's no ischemia, just some new Q waves that they didn't have before. It's because they've already infarcted, all right? And so that we can see that. And sometimes we'll see pathological Q waves in certain other conditions like hypertrophic cardiomyopathy. And again, I'm going to teach these to you as we go through the next several blocks, okay? So Q waves matter. Usually pathological Qs, or they have a criteria of being a certain size, that says 20% Qs in 2 hours, 80% in 8 hours. That's not an exact science. Were you guys taught that there's a timeline for Q wave formation during cardiology? I don't remember. Some people are saying yes, some people say, I don't know that you guys were in the same cardiology class. You might not have been. It's hard to remember stuff from last semester, right? I told you guys a story that when I got to phase 2, that I felt really stupid. Have I told you guys that before? If I haven't, I did. When I went through IPAP and I got to phase 2, it was my first rotation. I felt so down. I was like, IPAP didn't teach me anything. And I was asked a question, I think in ENT, about something, and I was like, I don't know, sir, they didn't teach me that. And I went home that night and I pulled out my old notebook from phase 1 that I happened to have because I used to get little pamphlets because we didn't have anything electronic then because it was, you know, during the dinosaur days. Don't laugh, Mr. Mendoza. Anyway, youngest person in the, anyway, I'm just kidding. So I went home and I pulled out my notebook and there it was, highlighted in 3 different colors, exactly what I was asked. I was like, you can't expect us to remember stuff at IPAP with all this information in flux. So I get it, okay, it's gonna be hard to remember just from last semester. Wait till you get to phase 2, it's hard to remember stuff. But I get it, I relate, and that's why we're doing this little recap, even though you just wanna get out of here. I get it. Okay. All right, so evolution to MI, this is important stuff. We only have a few slides left and you get on with your afternoon. And then Wednesday, we hit the ground running, okay? It's gonna be fast paced, you're gonna learn stuff, we're gonna go over stuff. All right, this is your crawl, walk cycle. Okay, normal, we agree, the top one is normal, that looks pretty normal. Okay, we can't really see a P wave, okay, but we're just looking at the ST segments and the, so the QRS, ST segment, and the T waves, all right? That's what we're looking at right here, and that's what's relevant for emergency medicine. So the top one's normal. The second one is a peak T wave, okay? Do you agree it looks kind of peaky?
Yeah.
All right, good. What do we think about this stuff? Yeah, you guys are already picking up on my lingo. That's bad, okay? Bad, okay? And the reason why it's bad is that we can see that there's some ST segment elevation. Can we see that sometimes in some people and it be normal? What if you see it in every single lead? Maybe they have pericarditis, maybe they have something called benign early repole. All right, so you gotta kind of correlate it with your patient. But if you keep letting it go and it looks tombstone-y and eventually looks like these two, it's undoubtedly a STEMI, all right, or at least in those leads. That's ST segment elevation. So that's what we're looking for, is evolution of ST segment elevation. Remember, by definition, it has to be elevated more than 1 millimeter in 2 contiguous leads. So this is by definition more than 1 millimeter in this one lead. And if I showed you an ECG and it had that in a contiguous lead, that's STEMI until proven otherwise, okay? All right. What about this? What is this thing? What's it? This is a Q wave and then just kind of a rounded circle. What do you think about that? Have you ever seen a QRS complex or ST segment look like that? Me neither. Okay, I would say it's tombstone-y though. I don't usually see this on an ECG. And then what about this? This is a Q wave with a tombstone and T wave inversion. Okay, not good. That would be bad. Okay, all right, moving on. All right, so remember, contiguous leads, we have to know what goes with what, all right? So just to remind you of what you've learned already, when I'm looking at an ECG, I'm looking at rate, rhythm, axis, morphology. The morphology being specifically ischemia or STEMI, because I'm on the hook for it. I have to write no STEMI. So what I do is I look at this ECG and I start up here. And I look at the first lead lateral, and I'm gonna go 1 and L, and then 5 and 6. I look at them all together. I look 1, L, 5, and 6. Do I see any ST segment elevation or depression? No, no, no. Moving on. The next thing I do personally, because I'm emergency medicine mind focused, is I'll go 2, 3, and F, which is the inferior portion of the heart, all right? I'll say, do I see any ST segment elevation, depression? Yes, no, move on. Then I go to the AVR, which is a monster by itself. If you see ST segment elevation in AVR, you should be concerned, okay? Pay really close attention, especially if that patient has chest pain. Especially if in this lead right underneath it, there's a lot of T-wave inversion. That's an LAD lesion, like that's an MI happening, but you won't find it in your STEMI criteria, okay? I'm not gonna trick you on the test, I'm just teaching you, okay? I'm not gonna do that to you, because I'm nice, okay? No matter what the other classes said, okay? All right, so I'll go R, because it's kind of by itself, a monster by itself, and I will kind of compare it with AVL, even though it doesn't say, it doesn't correlate color-wise, it does correlate in real life. And then I'll go anterior septal, okay, V1, V2, V3, and V4. That's how I personally look at ECGs. Has anybody else ever looked at them like that before? Will you look at that, like, looking forward? Is this your new way?
Yes.
Yeah, good, all right, good. Pull some of you to the EMED dark side, all right? This is what the definition of contiguous is. Contiguous isn't this one with this one. It's contiguous as it correlates with parts of the heart, okay? And then there was this acronym I think you guys learned. If I see ST segment elevation in one area, I'm looking for reciprocal changes somewhere else. What was that acronym? PAILS, P-A-I-L-S, right? So if I saw ST segment elevation in 2, 3, and F, where might I be looking for reciprocal changes using the PAILS acronym? Lateral, that's right, P-A-I-L, right? So I'm gonna be looking at these leads over here for reciprocal changes. If you see those two things together, that's definitely a STEMI, okay? You still with me? All right, you guys are doing great. Did you guys get to eat today? Did you get done early enough to actually eat? Okay, I'm just worried about your nutrition and stuff, okay? I am, legit, okay? Okay, so again, with this block, you kind of need to know what arteries correlate with the areas of the heart, all right? So posterior, was this deeply ingrained in your brain? Did you get hammered over posterior MRIs and the carousel sign during cardiology? Did you see a bunch of pictures of carousels during cardiology? Okay, that matters, because that's the one MI that we're designed to miss, all right, as clinicians in general, not PAs, just clinicians in general. That's the one that we're designed to miss. So posterior, you'll see it in V1, V2, and sometimes V3, and that correlates with the right coronary artery, all right, that's your posterior MI. Inferior, we already talked about, it's leads 2, 3, and F. In which artery correlates with the inferior heart? Yeah, it's usually the right coronary, but it can be right or left, but it's almost always RCA. All right, what about lateral? That's 1, L, V5, and V6. Okay, circumflex, okay, in most people. And then anterior, this is the big one. This is the widowmaker. Okay, the other MIs, like, not so sexy. Inferior can be sexy, but the sexiest one is these big anterior ones. Those are the widowmakers. Which arteries associated with the anterior MIs? The LAD. Okay, that's the big one. That's the big widowmaker. When they say widowmaker, they're talking about anterior MIs. They're talking about LAD lesions. Okay. All right. We talked about Arpaio's acronyms, and you guys already remembered that because you're fantastic and you actually remembered stuff from last semester. I remember people from last semester, so you're better than me. If somebody has ST segment elevation and it's meeting STEMI criteria, we're looking for reciprocal changes. The main thing we need to know is there a STEMI, yes or no? Okay, and then we write yes STEMI, and right away at AMC, I'll say, clerk, please call a code STEMI. As soon as I see the ECG, where's this patient at? Call a code STEMI. And one time I had a code STEMI, like this patient came in, he had crushing chest pain, he looked diaphoretic, and he looked like an MI. They brought him in, I stood at the bedside, they did an ECG, I looked at it, I was like, call a STEMI. Well, the cardiology team happened to already be in the ER evaluating another patient that wasn't a STEMI, and I didn't even know, I didn't get to talk to the patient or anything, they literally took him and just took him right to the cath lab. Like, I didn't do any labs, or I didn't know his name. I felt kind of cheated out of the process, to be honest with you. So sometimes it can happen really quickly if you're at a facility that has a cath lab. Other times, it can be evolving, and like when I work at Uvalde, I actually have to, if I said a code STEMI, nobody cares, I'm the person, the N of one that has to take care of the patient, me and the nurse, right? And then we're gonna have to try to stabilize them to get them transferred. So it depends on where you're working. So let's just kind of work through this a little bit. Come on, you can play my silly game for a little while. I'll get you out of here. This is for you, I promise. Okay. So I haven't seen it. Just to orient you, this is an ECG. Okay. All right. So we're looking at an ECG, and what's our criteria? What's the first thing we look at? Rate. Very good. After we confirm it's the right patient and stuff, right? Okay, rate. All right. So how do you guys want to determine rate on this? Do you want to try to find a couple of QRS complexes and see how many boxes are in between? What do we think the rate is? Do you guys see in the back? You guys got it on your computer screen, right? About 75. Very good. You guys are already way smarter than last class, but don't tell them I said that. Okay. They're very emotional. Okay. Rate. Rhythm. Okay. Rhythm. What's our rhythm? Looks pretty regular, right? All right. I see a P before every QRS. So it's a regular sinus rhythm, rate of 75. Rate, rhythm. What about axis? We look at 1 and F. Are we upright in 1? Oh, we're upright. Huh? Okay. What about F? Maybe a little down. You might say this might be somewhat left axis, okay? It's a little more down than it is up, so I'll give that to you. Very good. Okay, so a little left axis. So we got rate, rhythm, axis. Now let's go to morphology. And in ER, what do we care about? STEMI or ischemia, okay? And I do it systematically, so just play my silly game. We're going to look at 1, which goes with L, and 5 and 6. So do we see any ST segment elevation or depression in 1? Yes. All right, let's go to its partner, right? And I'm not going to talk bad about this part of the heart, but there's just multiple partners, okay? They just maybe they have an open relationship or something, okay? There's multiple partners in this one. We got 1, we have L that goes with that goes with 1, and we see ST segment elevation in L. Yes. Okay, now what else goes with these guys? 5 and 6, do we see any ST segment depression or elevation? Yeah, there's definitely some, a little bit of elevation here, or some people might call hyperacute Ts, all right? There's definitely some elevation. So already I have enough information to call a code STEMI, all right? Even not having seen prior ECG, this is a STEMI, you can see it from across the ER, all right? Where am I gonna look now for reciprocal changes? Tails. Oh, this is hard. Where's this lateral? Septal, right. We're going to go septal. So do we see any reciprocal depression in the septal leads, which is V1, 2, maybe even 3? Do we see any depression? Yeah, so this is definitely a STEMI. So what kind of STEMI is this? A lateral STEMI. And if I'm honest with you, this is the boring STEMI. It's boring. I mean, it's exciting that we called it, but it's kind of boring. Like most of the time, these patients will do well, okay? Just saying, okay? It's less exciting than other STEMIs. All right, everybody with me? Everybody see that? All right, oh, I forgot to even look at 2, 3 enough. Should we at least do our due diligence and look at it? Probably, right? So we looked at everywhere else. Let's look at 2, 3, and F. Uh-oh. Are there some reciprocal changes there too? So this is pretty big. So maybe it's not so boring. Okay, so it's a big enough STEMI to cause reciprocal changes not only in the septal leads but also inferior. All right, very good. So lateral MI. Which vessel is involved? Circumflex. You guys are nailing it. Drop the mic. Okay, go to the next one. Let's do this. By the time you get your exam, it's going to be so easy for you. Okay, so what's our rate? Let's be systematic. Rate, rhythm. Okay, I agree. 60 is the rate. Is the rhythm regular or irregular? Is it sinus or not? Yeah, there's a P before the QRS. P, P, P. Okay, so it's a regular sinus rhythm with a rate of 60. What does a rate have to be bradycardia? Less than 60. So it's still sinus. Okay, good. Okay, rate, rhythm, axis. Are we upright in 1 and F? Yep, so it's normal axis. Now let's look at morphology. Okay, I notice I'm skipping over intervals just because it's hard. I don't have them displayed and we don't have calipers and I'm skipping that. But again, we're hitting the highlights here. Okay, so morphology, we're looking systematically. Okay, we're gonna look at 1 and L. Do we see any ST segment elevation or depression? Full depression in L, but not so much in 1. Let's look at the other lateral leads. Any depression in V5 or 6? Maybe a little in 5. Okay, that's a little concerning. Okay, let's move on. Let's look at 2, 3, and F. Lots of elevation there. And what part of the heart is that? Inferior. So it looks like an inferior MI. And here's another little trick that you may or may not have learned. The scary part about inferior MIs is only if they involve the right ventricle. Inferior MI doesn't always involve the right ventricle, but it can sometimes. And that's why we do a right-sided ECG. So when you see this, 2, 3, and F, elevation, we're gonna order a right-sided ECG. But also there's a little clue that you can look at just right now to say, is there a right ventricular involvement? If the ST elevation is greater than 3 than in 2, it probably involves the right ventricle. Just a little eyeball test. So do you guys think that lead 3 has more ST segment elevation than lead 2?
Yes.
Yeah, so this probably involves the right ventricle. So why does that matter? That's right. Those patients are the preload dependent patients. Those patients, so not all inferior MIs can't get nitro or morphine, which I don't give morphine anyway for MIs, and that's something else we'll talk about later this week. But it's definitely the people with the right ventricular involvement. Those are the ones that are preload dependent. So if you give this patient nitro or morphine and you drop their preload, that can be really bad. They can actually arrest. All right, so that's why it's important to differentiate, which is why we do a right-sided ECG. You guys remember that? Were you taught that before? 3 is greater than 2? All right, committed core. Okay, so we got ST segment. We already got a STEMI, 2, 3, F. We have some weird changes going on in the lateral leads, some ischemia. Okay, let's look at AVR. Anything going on there? Nah, kind of boring. We already identified here. What about the anterior leads? If it's an inferior MI, where should the reciprocal changes be? Lateral. Does that make sense with what we're seeing? Do we have some lateral reciprocal changes? Absolutely. So this is an inferior MI with right ventricular involvement. We're still going to do a right-sided ECG. We're going to make sure we have IV access on this patient in case they drop their pressure. And we're going to be very careful about nitro or any kind of morphine in these patients. You should, and if you're not sure, you should always just consider all inferior MIs to involve the right ventricle. But if you are really astute, you can look at 3, and if it's greater than 2, it's probably right ventricular involvement, or just wait for the right-sided ECG. All right, you with me? We're almost done, y'all. Just a few more slides. And what vessel is this? RCA, usually. Very good. All right, so let's look at this one. This is even smaller, so it's going to challenge you, but you can look at your screen. Somebody tell me rate. Perfect. Rhythm. Yeah, there is an irregular component here. The rest of it looks pretty regular, and then it isn't. So they could have like just like a sinus arrhythmia, right? Is it a sinus rhythm? There's a P before every QRS, so it's a sinus rhythm. Sometimes you can just have one offbeat, but in general, if you look at all the others, they're pretty regular. Do you guys agree?
Yes.
Okay, but maybe just had a single arrhythmia beat, okay? So rate, rhythm, axis. What's our axis? You look at 1 and F. Yeah, it's normal. Rate, rhythm, axis, now morphology. What do y'all see? I'm letting y'all do this. I'm gonna walk you through it. You got it. We walk through the first 2.
2, 3, and F, correct?
Okay, so you see some ST segment elevation in 2, 3, and F. Does everybody agree? Those are contiguous leads, absolutely. Okay. What else do we see? 3 is greater than 2. Okay. You're picking up what I'm putting down. Okay, I like it. What else? We see anything else up in here? There are some reciprocal changes. Where are they? So yeah, we got a little bit in 1 and L, I would say, and a little bit in the anterior leads, V2, V3. Uh-oh, there's ST depression in V2, V3. What could that mean? The whole carousel sign thing? Remember that? But you've already seen a blatant STEMI in 2, 3, and F. So is it inferior, posterior? Yes, it's both, right? So you would at some point, because it's 2, 3, and F, you'll do a right-sided ECG, and that depression in V2 and V3 are just reciprocal changes from the giant STEMI. So don't talk yourself into saying this is just a posterior MI. Make sure you pick out the blatant STEMI and realize that that's probably some reciprocal changes, all right? I'm not gonna trick you like that on the exam. I just want you to be cognizant. If there's inferior involvement, we're going to do a right-sided ECG. If there's nothing going on in 2, 3, and F, and we see isolated only ST depression in V1, 2, or 3, just isolated, then we do the posterior one. That's your posterior MI. But if you see a blatant STEMI somewhere else with some reciprocal changes in the posterior or V2, V3, those are just reciprocal changes. Does that make sense? Posterior MIs are isolated. Okay, everything else looks fairly normal. Are you with me? Okay, that's a right ventricular infarct. Okay, good. And you said 3 was greater than 2, so it's probably, yeah, right ventricular involvement. This is the last one I think I'll make you do. Okay, I lied. There's one more after this. This will help you be better, I promise. What's our rate? Yeah, 50 something, is that what you said? Yep, I agree, okay, and then, rate, rhythm, regular, do we see a P wave? No. Mostly, yes. Kinda hard to tell some down in here, right? Okay, a little bit of activity, but there's mostly P waves, so it's mostly sinus, so it's sinus bradycardia, it's a regular rhythm. What's our axis? We're upright in one. It's kind of isoelectric almost here, so it might be a little left axis deviation. So rate, rhythm, axis, down morphology. What do y'all see? Ooh, it kind of looks delta, like a delta wave. Okay. But unfortunately, the PR interval is normal, so that might just be a little artifact. But good. There's like a weird upstroke here that almost looks like a delta, but the PR interval is normal. So anything else? Any ischemia or ST segment elevation anywhere? So yeah, we just talked about this. So in V2 and 3, there's isolated ST depression. Okay? We have a little bit of elevation in 3 and F, but it's not greater than 1 box in F. Is it? Does it look like it's greater than 1? It's pretty close. Okay? It's almost meets STEMI criteria there, but definitely this V2, V3 is significant depression. It's supposed to represent that carousel sign for our posterior MI, in which we would do a posterior ECG. So when we do the posterior ECG, this is what it would look like. What do y'all see with that? Absolutely. Okay, so this is what you would see in a true posterior MI. Okay, very good. You guys nailed it. Last two. Two more. This one and one more. You're welcome. It's gonna be fun. Come on. You're almost out of here. It's hard to see this one. I agree. It's hard to find good ECG images. Yeah, what's the rate? Okay, great. What's the rhythm? Okay, and? Is it sinus? I don't see a P wave. Okay, what else do we see? Somebody say it with conviction. Just do it. What is it? Okay, normal axis, good. Rate, rhythm, axis, morphology. What do you guys see? Yeah, we see ST segment elevation in V1, V2, V3. They not quite criteria, so that's anterior. Is that a STEMI? Where would there be reciprocal changes in an anterior STEMI? 2, 3, and F. Do we see any depression in 2, 3, and F? Yeah, do you have to have reciprocal changes? No. No, you do not. So you guys nailed it. This is an anteroseptal STEMI. Very good. Last one. Just so you know, 30% of STEMIs do not have reciprocal changes. Okay? 30%. 3 out of 10 won't have any. So you guys nailed it and you didn't get tricked. So good job. Last one. All right, rate. We'll take your word for it. Okay? Rhythm. Okay? And is it sinus? We always need to know if it's sinus or not. Is anybody completely lost? You are? Just because you can't see this one, or just in general? Okay, yeah, this one's hard to see, I know. So, actually, somebody said the rate was 60. Is that why you're confused? Because it's actually more than that? 300, 150, the rate's 100. So rate is 100, rhythm is regular, it's sinus. We're upright in 1 and F, is that right?
Yeah.
So it's normal axis. Where's the morphology? Yeah, again, we're looking at the interior, right? V1, not so much, maybe V2, V3, V4, there's ST segment elevation. Do you agree? Okay. Do you guys see any reciprocal changes? This is another example how not all MIs have reciprocal changes. This is another interior MI, okay? All right, are you guys with me? Was that a good little review?
Yes.
I've actually never done that for a class before, so I made it for you all, just to kind of go over so that when you see but it'll be blatant, all right? So do know your anterior, your lateral, your inferior, and your posterior stemmies, and know generally which vessels control what. And then the more important salient things that we're gonna talk about later this week is how to treat them. Are there any questions about anything we covered? They have thrown me off my game because I like to actually teach all those other blocks and I had to do it remote. And I just feel awkward about that because I don't get to really hit on the ultrasound images and stuff like that. So I try to do a review to try to focus you. But as the course continues on until test time, please feel free to reach out. I'll do some review and some more images and stuff prior to test day. Are there any other questions or clarifications about anything we've covered? Okay, so we'll hit the ground running with acute coronary syndromes, I guess, on Wednesday, and then everything else will go in order as it is on Canvas. Okay? No other questions? All right, y'all can make like babies and head out.